One of her children, excuse me, is a doctor. She came in with her husband and one son, and her story was like this. In 2011, she had esophageal cancer. She had trouble swallowing, 26-pound weight loss. She was worked up. She had the usual treatment in a big fancy-dancy cancer hospital. She had chemoradiation first. The cancer went totally away. Still, I guess nothing would deter them. They removed her esophagus anyway. In the pathology report, there was no cancer there. Wow. They removed it anyway. And she was doing okay. She's plugging along okay. She came to me, and she told me for the last 4 months, she's had hoarseness. Hoarseness means can't talk right. That's hoarseness. And she's losing air. So she got worked up with a PET scan there at that place, and there was a mass by the voice box and trachea, another mass by the lung. Now, the surgeon who removed her esophagus sent her to another surgeon who looks at the voice box to see what's wrong. Well, the PET scan already showed that the vocal cord's not moving. The vocal cords, there's two of them. They have to oppose each other to make your voice sound like your voice sounds. If they don't oppose each other, then your voice sounds like this. You can't make that sharp, clear sound. So he sent her to the ENT for laryngoscopy, which is a procedure under anesthesia, but they weren't ready to fix the vocal cord. I asked her, were they going to fix the vocal cord, put a little Teflon in so the vocal cord's opposed? She said, no. I said, well, if he was going to look for the cancer, I said, well, but the cancer's on the other side of the wall. If you're looking down and looking at your voice box, the recurrence of the cancer's on the other side of the trachea. You can't see the cancer from laryngoscopy. It won't work. It's like if you're looking in this room, what's on that room, you can't see what's in that room when you're in this room. Well, it didn't make sense to me. And when I explained it to the patient and her family and her daughter, the doctor, it didn't make sense to them either. There's certain ways to biopsy if she wants a biopsy. Not everyone needs a biopsy. She already has known cancer. This is a recurrence of the cancer. There's a big mass there. We also did some other things that no one else did for this woman. While they were there in the room, we spoke to the radiologist who read the report. And I asked the radiologist, so where is this mass? And he said, well, the mass is by the trachea. And I said, well, how far is it from the surgery? He said, well, it's 5 millimeters from the surgery. That's about 1/4 of an inch. It's like right next door. So it seems like when the surgeon operated on her, he probably spread the cancer cells to that area. The surgeon told her when he saw her earlier in the week it was far away. It had nothing to do with the surgery. Well, how did it happen to be next to the surgery? And how did it happen to be next in the chest to the surgical site in the chest? These things don't just happen. And we see it very frequently that when surgeons go in, they actually can spread the cancer cells around. So he had no good explanations for her. We talked about cancer treatment options. We have the PET scan. We have the pathology. She has 2 sites. She hated the chemotherapy. She had chemotherapy before her surgery. She hated it. She got so sick. Again, what is radiosurgery? Radiosurgery allows us to focus in this case, on these 2 nodules, one next door to where the surgeon cut in the radiation field. Yes, we can re-irradiate, even though she had standard radiation. That's what we do. We probably have more experience than anyone else in the world re-irradiating cancers because normal radiation is not so effective. The biology of radiosurgery is very different than the biology of standard radiation. Standard radiation radiates larger areas with lower doses more slowly, and cancer cells can resist that, whereas a few treatments that are more focused, more intense, directly to the cancer are much more effective, and our success rate in esophageal cancers, even with recurrence like this, is more than 90%. And that's true in the radiation field. It's true in the lung where she's got the second metastasis. We offered her biopsy if she wants. She's speaking to her daughter. We're trying to fix her voice. We gave her the name of a good throat doctor to fix the voice. Talk about radiosurgery to these two areas. Obviously, there's other treatments available if she wants, but this is a bookend to the prior case. The Italian-born man married to the Filipino nurse who had a wonderful response just within days after treatment. So we hope to get the same good results for this woman, to put her cancer in remission, to get her voice back, and get her back to where she wants to be. So, if you have questions, call us. We're at 800-321-0710, 800-321-0710. That is what radiosurgery is all about. And there's a new report about esophageal cancer, surprisingly enough. It was published in Health Day. That said people who smoke and drink are nearly twice as likely to develop esophageal cancers as those who have only one of these habits. Previous research has shown that smoking and drinking are risk factors for esophageal cancer, but this is the first study to show the risk associated with smoking and drinking combined. And the authors, which was published in the American Journal of Gastroenterology, published in April 22nd, said, quote, "Our study suggests that not only do alcohol and tobacco play an important role in the development of esophageal cancer, the combination of their use markedly increases their potency as carcinogens." This is Dr. Babu. So this year, 18,000 Americans will be diagnosed with esophageal cancer, and more than 15,000 will die from the disease. So he's telling you that the usual therapy, if 18,000 are diagnosed, 15,000 die of the disease, that means a death rate of about 80%, that we have to do better. Now, it's true that patients with esophageal cancer have a 20% improvement compared to those who were diagnosed 20 years ago. We have work to do, and the same old treatment may not be so fantastic. Might be time for a change for people with esophageal cancers and other cancers who want more effective, more focused treatment with less side effects. In the good news department, we had a patient, a black man, came in, 50 years old, had prostate cancer, Gleason 7, PSA 9, came for treatment. He's married, works, great guy. His PSA now came in this week after treatment just this year. It already has fallen to 0.6. And he's sexually active and not leaking any urine and fully intact. Normal physical exam, in remission with a low PSA, most likely is going to have decades of great news. So that's the good news department from Radiosurgery New York. Another patient I want to talk about a little bit today, a woman who is very young. She's 39 years old. She's from Dominican Republic. She's been here many years. Very lively. She developed breast cancer at age 31, right-sided breast cancer. She had mastectomy at a big hospital in Manhattan. She chose to have bilateral mastectomies. I guess she was at age 31. She chose to have bilateral mastectomies. So she was led to believe that if she had bilateral mastectomy, she'd be better off. Well, it didn't work that way. She had chemotherapy and tamoxifen, and within a short period of time, she got recurrence of the cancer. Now, you can say, if the breast is removed, can the cancer come back? And the answer is yes. It came back right in the same area, except instead of the breast, it came back under the pectoralis muscle. So I would say the strategy wasn't a good one. And you know why I say that? Because there's not data to do something like that. So she did it and didn't have any radiation. She had radiation years later when it was really too late. Anyway, she had metastasis. She came to us for treatment of brain metastasis. And the beauty of brain metastasis treatment with us is that we can focus on the cancer and not hurt healthy tissues. And Then she came in this week. She'd just been in Florida last week. Came in this week and she said, oh, she's so tired. She can't stay awake. She's so sleepy. Well, she'd already gone to this famous hospital and seen all her famous doctors. And I said, we need to check your calcium. We checked her calcium. It was elevated. We got her treated. And within 12 hours, she was back to normal. She woke up, was feeling fine. Many people with, and I'm not telling you about calcium like an advertisement. That's stupid. This woman had hypercalcemia. Sometimes cancers make hormones that cause the calcium to be elevated, and it can be treated, put it in remission, so that within 12 hours she was back to normal. Normally she's a bubbling, spry woman. She runs a cancer site, a cancer website, tries to help other people, which is fantastic. We have her doing fantastically. She's happy. She woke up. She's feeling fine. And that's what we mean. See the doctor. When you call us, you don't get the machine. You don't get the secretary. You get to see the doctor. You want to speak to the doctor day or night? The doctor's available day or night. We have patients come in that go to other places in cancer hospitals. Oh, the doctor can't speak. He can't see you. You can't have a cell phone. You can't speak. He can't see you. Well, that's not the way we are at Radiosurgery New York. You want to speak to the doctor, you can speak to the doctor day or night, 7 days a week. This woman came in, diagnosed the problem, got her treated, and she's back to normal. Isn't that where you want to be? Isn't that where everyone wants to be? And that's what we want for our patients. We have a caller, Ted from Long Island. Good morning, Ted.
Good morning,
Ted's
Doctor.
my brother's name. Ted's a good name in our family.
Well, thank you. Ted means good. It's from the Greek.
Yeah, is that right? Are you Theodore? Is your real name Theodore?
Yes, sir.
Well, welcome, Theodore.
Thank you very much. You're a wonderful sounding person.
Well, I am wonderful sounding. I'm even better than sounding. I am.
I know you are. I'm sure. And my question, to take up as little of your time, precious time as possible, is this: I had a cystoscopy that revealed that I had 2 polyps in my bladder, rather than not tumors, and of course the biopsy has to determine the final diagnosis.
Right.
But my question is, does radiosurgery destroy polyps too?
Well, the issue really, you said it's not a tumor, but actually any growth is a tumor. So anything is a tumor. It can be a cancerous tumor or a benign tumor.
Okay.
So in your case, you're apparently waiting for the pathology to tell you if this is benign or cancerous, right? They haven't told you that
no,
yet.
I didn't have the polyps removed. I'm asking you, can you destroy the polyps with
Well, we don't want to
radiosurgery?
destroy the polyps. We want to find out what they are. If they're benign, that's one thing. If they're cancerous, it's a totally different thing.
Okay.
So I would urge you to have a cystoscopy, which is to have a urologist look in the bladder, do a little biopsy of it. It's a minor procedure. It should be pretty easy. And find out what this is, and then give me a call, and we'll go over the results. If you have a urologist you like, great. If you need a urologist that you like more, we'll hook you up with somebody. But it's better to know what something is than to guess in this case, because you don't know what it is. And some doctors use different terms. They use polyps and lesions and tumors and blah, blah, blah. And really you have to be precise, because you want to know what you have and get the best possible treatment.
I was told that I was going to be treated as an outpatient. They were going to remove the polyps and do the biopsy.
Well,
and
get
tell
that
me
done.
What.
Yeah, get that done and call me back.
Wonderful. Thank you.
Just call the number 212-CHOICES, 212-CHOICES, which is 212-246-4237, 212-246-4237, and I'll be happy to speak with you anytime, day or night. And we'll also mail you a package of information if you wish.
Thank you, and my best wishes in regards to your brother, Ted.
Yeah, all the Teds. Teds unite. We used to have a president, Theodore Ted Roosevelt, right?
That's
Teddy
what
Roosevelt.
I was always proud of that name.
Yeah,
actually,
good name.
My name on my birth certificate actually was Tobias, and everybody and my family